Hello, hello, I'm back. And we'll continue with potassium, which is a really important electrolyte, which I know most of you are familiar with. Makes skeletal and cardiac muscles work correctly. So when there's a deficit or there's a problem with it, obviously we're going to have some skeletal and cardiac muscle issues. Achieve electrolyte in intracellular fluid. So again, if we took the potassium level of inside a cell, it'd be about 140 milliequivalents, but outside it's only about 4 milliequivalents. Plays a vital role in the transmission of electrical impulses. That's why it becomes very important in cardiac. Food sources are important to know because sometimes we have to teach patients foods that are high in potassium to avoid or foods that are high in potassium we want them to eat. Potassium is excreted by the kidneys. The stomach contains a large amount of potassium, so vomiting is going to contribute to a hypokalemia. Normal potassium levels in general are about 3.5 to 5.3, depending on what the lab is. Hypokalemia, potassium less than 3.5. What are the causes? Diuretics is a common cause because the potassium is excreted through the urine. Corticosteroids, sodium retention, water excretion, right? We have that imbalance right there. GI suction because potassium concentrations are high in the stomach, vomiting, diarrhea, same concept. NPO, so people just don't take enough potassium, and that's why we replace potassium a lot in the ICU because it's such a small amount and they're not really taking any oral intake, so we have to replace their potassium. Kidneys are lost with age. The kidney just excretes more with age. Remember your difference between your Addison's and your Cushing. So Cushing syndrome, we have high sodium, low potassium, and you're going to see in Addison's, it's going to be the opposite. So keep in mind, you're going to have to know those. Alkalosis. So this is an important thing that we need to keep in mind when we talk about alkalosis and acidosis. So when we have in our blood an alkalotic environment, for some reason the patient's in some type of an alkalosis regardless of the cause, and the blood is alkalotic, maybe they have, it's a common cause of alkalosis, metabolic alkalosis. We have their NG tube hooked up to suction. It's just sucking all the acid out of their stomach, so they're in just this chronic alkalosis. When they're in alkalosis, the potassium is going to move into the cell, and they're going to look like they have a low potassium because the potassium doesn't want to stay in the blood in an alkalotic environment. I remember by alkalosis, a low K, where acidosis is the opposite, right? Acidosis, we see the potassium come out of the cells into the blood, and they appear to sometimes have a normal potassium with acidosis, but when in fact they don't. Once the acidosis is cleared up, the potassium is going to run into the cell. So alkalosis, serum potassium is low. Signs and symptoms are important to know. Belly, muscles, heart. Paralytic ileus, hypokalemia, low kind of gut. The gut slows down. Abdominal distension will probably be next since there's no peristalsis. Low gut, but the muscles cramp. Muscle cramp, and then it goes into muscle weakness. And here's the big one right here. EKGs, we will see ventricular ectopy for hypokalemia. You have a patient that is having PVCs. First thing we want to do, check their electrolytes, most particularly hypokalemia. Since it's only 4, it's going to deplete quickly. So ventricular rhythms, ventricular ectopy, and then some other progression characteristics for hypokalemia on the EKG. A flattened T wave, and then it will start to invert. An ST segment depression, and a U wave right here. This is characteristic of hypokalemia on an EKG. Classic test question. T wave inversion, ST depression, and a prominent U wave. See how that goes there. Now I have the hyperkalemia right here, which we'll talk about coming down here. So I put it together, but we'll talk about this one in a minute. So to make sure you know this. Treatment, how do we treat it? High potassium diet to replace the potassium. IV or oral potassium chloride increases the serum potassium. When administering IV potassium, be sure to check for proper kidney function and good urine output. We don't want to be giving somebody a bunch of potassium if they can't pee. Supplementation, will give them oral is preferred. Okay, if we can replace it orally, we certainly want to do that. If it's chronic or mild, oral is preferred. If it's acute or severe, we have to use IV. If IV is required, a maximum of 10 milliequivalents an hour in IV peripheral or 20 milliequivalents an hour in a central line. IV can cause serious or severe burning sensation peripherally, and PO can cause GI upset, so give with food. If acidosis is present, we want to correct the potassium first. Okay, remember that? Once somebody has potassium, it could look like they have a normal potassium, but if they're acidotic and we correct the acidosis, they're going to become hypokalemic. Generally, it takes about 3 to 4 hours for potassium to show up in the lab values. And just as a general rule of thumb, potassium may be expected to increase 0.5 milliequivalents for every 100 milliequivalents of IV potassium infused. So if we wanted to go from a 3.5 to a 4, we need to give approximately 100 milliequivalents, maybe anywhere from, could probably say 80 to 120. But this is just kind of a general rule of thumb. Or for 1 point, you can just kind of remember, might be easier to remember for 1 point, 200 milliequivalents, right? 0.5, 100. If we wanted to go from a 3 to a 4, we need to give them 200 milliequivalents. Okay, let's talk about some hyperkalemia, serum potassium greater than 5.3, signs and symptoms. Total opposite of what we just said. Now they have an increased gut, hypercontractility and GI motility, and muscle twitching, tingling, and burning. So muscles, the gut, the muscles, the heart. Keep in mind those symptoms. Cardiac arrhythmia, bradycardia, EKG changes are a peaked T wave. Okay. It progresses into a flat or no P wave, which progresses into a wide QRS complex, which can also go into ventricular dysrhythmia and asystole. Sometimes when somebody's hyperkalemic, they may present first with bradycardia, then progress into the peak T wave, flat or no P waves, wide QRS, then ventricular tach, fib, and possibly going into asystole. So a different look in the EKG for hyperkalemia, know it. Regardless of potassium imbalances, the severity of the symptoms always depend on how fast the serum potassium is rising or falling. What are causes of hyperkalemia? Obviously, one of the most common, if a patient that has high potassium, I want to look at their renal function. What's their BUN and creatinine? Renal insufficiency. Kidneys aren't able to excrete potassium, and hyperkalemia is certainly a sign of acute kidney injury. IV potassium overload, we've given them too much potassium. Anything that's going to crush the cells, a crush injury, a burn injury, wounds, the cell, remember the cells are filled with potassium, so any of those are going to cause an increase of potassium, rhabdo. A tight tourniquet, if we put a tight tourniquet on somebody's arm, the red blood cells rupture, and inside of the red blood cells are a bunch of potassium, and it can look like they have hyperkalemia, and sometimes that's manifests like we see maybe somebody with a potassium this morning of 3.5 and in the afternoon it's 7. We have to be a little bit suspicious that maybe there was problems with withdrawing the blood from the catheter, or the tourniquet was on too high. Hemolysis of a CBC sample, same concept, pseudo hyperkalemia, because the CBC, that the cell hemolyzed, the cell broke down, and the potassium spilled out. Keep in mind for dietary instruction that salt substitutes are usually made of potassium. So we have to be careful with patients who are taking salt substitutes and they also have some renal issues, because it can contribute to potassium overload. Potassium sparing diuretics. Blood transfusions have high levels of potassium. When we give somebody a lot of transfusions, it may look like they're hyperkalemic because of the bags do have potassium in it. ACE inhibitors, keep that in mind. That's important to know that an ACE inhibitor is an aldosterone blocker, just like a potassium-sparing diuretic is an aldosterone blocker. If we block aldosterone, then we have a loss of sodium and an increase of potassium. Acidosis, this is kind of the opposite concept of this right here. When somebody has acidosis, their blood is acidotic. For whatever reason we've talked about, DKA, somebody's in a respiratory acidosis, somebody's starvation, whatever, lactic acidosis, the shift of potassium out of the cell for hydrogen to get into the cell, okay? So the blood has more potassium. They could look hyperkalemic, but like somebody could also just look like they have normal potassium, and then when we correct that acidosis, it goes into the cell. So acidosis, we would see hyperkalemia. Keep that in mind. It's an important concept. And Addison's disease, adrenal insufficiency, the total opposite of Cushing's disease, where they have low levels of cortisol, low levels of aldosterone. So here we're going to see high potassium, low sodium. What about treatments? Treatment's very important for you to know. We want to get a stat EKG and hold any potassium retaining medications. Remove excess potassium with K-exolate, which is the sodium polyestyrene sulfonate, or there's a new one, I think it's called Veltassa, which the K-exolate binds and they poop out the potassium, and then that Veltassa, it binds and they urinate the potassium out. So any one of these binders here are very helpful for somebody with hyperkalemia, and if we have time, that's we want to use that. And I should probably put that here. I think I will. You guys can add this. I think it's VELTASSA, and it binds the potassium and they urinate it out. The potassium out. Yeah, I think that's something that they're using a little bit more commonly. Patiramir Veltassa is the medication. We want to stabilize the cardiac muscle with calcium gluconate, okay? So it directly antagonizes membrane actions of hyperkalemia. So this isn't getting rid, it's not getting rid of the potassium here, okay? It's just stabilizing that heart muscle and antagonizing that membrane against the actions of hyperkalemia. Then the main part of the treatment, we want to drive the potassium inside the cell. We want to get that potassium that's sitting in the blood, and we want to get it inside the cell so it can go to the kidneys and get excreted out. And we do that by giving them IV insulin, 10 units with D50. And when we do that, we the insulin acts like a key. The key opens the cell. The sugar goes inside the cell, and the potassium loves to follow that inside the cell, because remember we talked about insulin will decrease potassium. Sodium bicarbonate is really for the acidosis, okay? It just, the sodium bicarb will correct the acidosis and help drive the potassium into the cell. Another thing I don't have here are beta-2 adrenergic agonists like an albuterol. I'm not sure how many of you see that. It's not super effective, but it's the same mechanism as insulin and bicarb. But just to kind of wanted to bring up the albuterol in case you see that in a test question. It's just not something that I think is used that often. And then certainly if it's severe or refractory and we can't correct it, dialysis is going to be something that can be helpful for that. Okay, thank you.